Good evening, everyone. My name is Jen Nolan, and I'd like to welcome you to the 9th webinar in Arthritis and Osteoporosis Victoria's Musculoskeletal Health webinar series. Tonight's webinar will examine the management of femoro-acetabular impingement. Before introducing our presenters for this evening, however, I just have a couple of housekeeping issues to run through. Firstly, if you have any technical difficulties during the webinar, please refer to the message box on your screen. You can type a message at any time that will be read by the webinar organiser at Redback Conferencing. If you are listening via the phone, you'll notice a small time delay between the audio and the screen. This is normal, so don't be concerned. Also, whilst our presenters will answer questions after the completion of their combined presentations, you can actually type questions for them at any time. Can I suggest you don't leave your questions to the last minute, as we will aim to finish no later than 8 p.m. Australian Eastern Summer Time. I would also be very grateful if all participants could take a moment at the end of the webinar to complete the exit survey. It'll only take you no more than 30 seconds. Our first presenter for this evening is Professor Kay Crossley. Kay is the director of the Trobe Sport and Exercise Medicine Research Centre and is a titled sports physiotherapist. She maintains a strong research focus on optimising treatments for FAI, patellofemoral pain and osteoarthritis. Additionally, she investigates development and prevention of osteoarthritis following sports-related injuries. She has published extensively on lower limb injury and contributes to key sports medicine and physiotherapy texts, including every edition of Bruckner and Kahn's Clinical Sports Medicine. Our second presenter for this evening will be Dr. Joanne Kemp. Jo is also a titled sports physiotherapist of 20 plus years of experience. She's also a research fellow at the Australian Centre for Research into Injury in Sport and its Prevention, Federation University Australia. She completed her PhD at the University in Queensland in early 2014, and she is now also the director at BODYSTEM Physiotherapy in Hobart, and maintains clinical practice in Tasmania and Victoria. Without further ado, I'll hand proceedings over to our first presenter, Kay Crossley. Thanks very much, Kay.
Thank you, Genevieve, and thank you for the opportunity to present to you today via webinar and to do some work alongside Jo Kemp, who did her PhD with me a number of years ago. And a lot of this work has come about because of Jo's interest in the hip. And so I'm going to speak to you today about hip-related pain in adults and specifically about FAI. My talk will be, my talk will be focused on the causes of hip-related pain, excuse me, specifically FAI, but also labral pathology and chondropathology, and I will talk about evidence of surgical management, mostly hip arthroscopy, and then Jo will talk about conservative management following that. So I suppose the first question we need to address is, what is FAI? So femoro-acetabular impingement occurs when we have a bony lesion in the hip joint, and as a person goes into flexion and internal rotation activities, that bony lesion can cause impingement within the hip. The bony lesion can either be on the femur, which is known as a cam lesion, which is a bony growth on the anterior superior neck of the femur, or it can be a pincer lesion, which occurs on the acetabulum. And this talk today will focus on cam lesions because we know there's much more evidence around the relationship between cam lesions and osteoarthritis. So how do we measure a cam lesion? A cam lesion is measured from a radiograph using something called the alpha angle. To measure an alpha angle, you draw a circle of best fit around the femoral head. You then draw a line from the centre of the head to the centre of the neck, and a line from the superior surface of the head neck junction where it first departs from the circle, and where those two intersect is the alpha angle, and that alpha angle represents the cam lesion. And we know that in a normal population this angle is quite small, but in people with a cam lesion it's a much larger angle. So how do we know what that angle is? What angle can represent a cam deformity? And there's been some work done by Agricola from Holland, and he's combined the work from the Czech cohort, which is a large cohort in the Netherlands, and the Chinford cohort, which is a large group of people from the United Kingdom. And what they did was they combined these data together to get an indication of where the cut point was for an alpha angle. And on the y-axis we have the frequency of of people with a different alpha angle, and on the x-axis we have the actual angle itself. So what you can see is it has a bimodal distribution. So we have one hump and then a gap followed by a second hump. And that tells us a couple of things. One is that it's not necessarily accurate to get a mean of the overall number, because that doesn't actually represent where the majority of people lie, which is in that first hump. And so for the majority of people, their alpha angle would sit around 50 degrees. But we can see there is a cut point or a threshold around 60 degrees, beyond which there's now another number of people that have a larger angle. And so this 60 degrees is what is referred to as a cam lesion. And what their data showed was that these are two very small graphs, is that cut point is the same for both men and for women. So the Czech study had both men and women in it. And in the women, even though fewer people have a cam lesion, the cut point is still at 60 degrees. Whereas in the men, more people have it, and the cut point is also 60 degrees. So it doesn't matter whether you're a man or a woman, the cut point is about 60 degrees. So why does a cam deformity develop? There's been a hypothesis developed by Agricola, who's the researcher from the Netherlands, and he did a number of fairly small studies, two that have been published in the American Journal of Sports Medicine. The first one was a cross-sectional study, and the second one was a longitudinal study. And then they did a modelling study, which is this third study written down here with roles, of which Agricola is also an author. I'm not going to go through each of the individual papers, but I'm just going to give you a theory that they developed based on those three studies combined. And that is, during adolescence, we have a normal head-shaped development, which are represented here as A, followed by B, followed by C. And if everything is normal in the development, we then go to this graph D with the normal spherical head shape. However, if an adolescent is exposed to a lot of external rotation during adolescence, then we start to see this flattening of the growth plate, which we can see in the graph E. We then get a higher stress distributed to the head neck junction, which is due to these flexion and external rotation forces, followed by an extension of the growth plate, and finally, as we get towards the end of adolescence, we develop this cam lesion. So this is a theory based on one cross-sectional, small longitudinal study and a modelling study to give us an idea of how a cam lesion might actually develop. The same group did a small study looking at, is there a dose-response relationship? So this was in the British Journal of Sports Medicine. It was in one professional soccer team which had a prevalence of alpha angle of a cam lesion of about 50%. And they looked at when people started to play soccer at least 3 times a week. And what they found was there was a relationship between people's age of when they started playing soccer. So particularly the boys aged 12 and age 13, we see there's a much higher prevalence of cam lesions in those who are training more than 3 times a week when they're starting at that young age. So there seems to be perhaps a dose-response relationship that's occurring at this age of 12 to 13 in young boys. We don't have the same data for young girls, not because they don't necessarily develop a cam lesion, but no one's really studied this patient population. So we see that cam deformity is highly prevalent in the athletic populations. It appears that ages 12 to 13, so during this adolescence age group, seems to be critical for the development, particularly in boys. Most likely it only develops during skeletal maturation. The few studies that have looked at people over a period of time have shown that once the growth plates are closed, cam lesions do not develop. And it's possible there's a dose-response relationship between athletic deformity in adolescence, and so basically the amount of exercise someone's doing and the development of a cam lesion. And it's the movement patterns of flexion and external rotation that seem to trigger the formation of a cam deformity. So clearly we need more research in this area, but we certainly have enough evidence to say that this time of adolescence is the most important time for a cam to develop, particularly in young boys. So what about the relationship between a cam lesion and the risk of osteoarthritis? I said before, there are these 2 large cohort studies. The Kemp study was done in the UK, and they looked at 268 hips of a randomly selected sample of women aged 44 to 67, and they followed them up over a 19-year period. And they found that the risk of having a total hip replacement for every 1 degree increase in the alpha angle was 6%. So having a higher alpha angle increased your risk of having a total hip replacement over a 19-year period. At the same sort of time, Agricola published work from a Czech, which was the Netherlands cohort of 1,000 people with hip or knee pain who were a similar age, 45 to 65, and they divided theirs into either having a moderate cam lesion, which is an alpha angle greater than 60, or a severe cam lesion, which is an alpha angle greater than 83. And they found that both of these predicted end-stage hip osteoarthritis. So the moderate alpha angle or the moderate cam lesion increased the odds to 4% of having end-stage hip osteoarthritis, whereas the severe alpha angle or cam lesion of 83 degrees was nearly a 10% increased odds of having end-stage osteoarthritis at 5 years. But the second study actually allowed us to look at their data a little bit more, and so we can see that 17 of the 156 people with an alpha angle greater than 60 developed end-stage hip osteoarthritis, which is 11%. But 14 of the 56 people with an alpha angle greater than 83, which is 25%, developed osteoarthritis. The reason why we have this high odds ratio is that only 22 of the remaining people with an alpha angle less than 60 developed end-stage osteoarthritis. But if we look at the two higher categories, those with an alpha angle greater than 60 or an alpha angle greater than 83, we can see there's a large percentage of people who have these increased alpha angles or these cam lesions who do not go on to develop osteoarthritis. And so we need to try and work out, sure, we know that cam lesion is a risk factor for hip osteoarthritis, but what are some of the other factors that might place a person with a high alpha angle at risk of developing osteoarthritis? So as I said, in summary, having a cam lesion in middle-aged men and or women, regardless of whether they've got pain or no pain, does increase their risk for end-stage hip osteoarthritis, as defined as either total hip replacement or having grade 3 or 4 hip osteoarthritis. But we don't know anything about the risk of developing new or developing end-stage hip osteoarthritis in younger adults, including athletes with a cam lesion, so there's nothing we know about this group at the moment. And we don't know about the potential mediating factors such as strength, range of motion, movement patterns. And so can some of these factors, these more clinically relevant factors, actually mediate the impact of having a cam lesion on hip osteoarthritis? And that's actually the focus of our current study that we're doing here at La Trobe University in combination with Queensland Uni and Melbourne Uni, looking at the relationship not only of the cam lesion but also of strength, range, motion and function to the development of osteoarthritis over a couple of years. So we talked about what is a cam lesion, but how does the cam lesion become, or where does it sit in the spectrum of hip osteoarthritis? And so what we know from these large cohort studies, as I said before, there is this cutoff of 60 degrees to have a cam lesion, but then they're also able to work out the cut point at which point they had a greater risk of developing hip osteoarthritis. And that cut point is around 78 degrees. So if they've got a lesion, if they've got an alpha angle above 60, they have a cam lesion. If they've got an alpha angle above 78 or 80 degrees, they're much more likely to go on and to develop hip osteoarthritis. So what's the theory behind having a cam deformity? Is that it then becomes cam impingement. So as people go into these repeated flexion and internal rotation activities, the deformity creates stress within the hip joint and eventually causes cam impingement. And that's associated with decreasing function, increasing pain, lesions to the acetabulum, labrum and articular cartilage, and as we said before, eventually osteoarthritis. Where does the pain come from in cam impingement? We really don't have a lot of evidence for this at the moment. It's highly likely that some of the pain is coming from the highly innervated bone in the region, but also the labrum is highly likely to be a cause of pain. We know that the area of the labrum that's damaged in people with FAI is similar to where the impingement lesion occurs. And we also know that the labrum is very important in the hip, similar to the meniscus is in the knee, to distribute the contact stress, increase the joint stability, and is a potential source of inflammation. We know that labral pathology is associated with an increased risk of chondropathy, so early hip osteoarthritis and also later disease. And so we believe there's a bit of a continuum where a person might initially start off with FAI, they then develop labral pathology, and eventually they develop early osteoarthritis and then later osteoarthritis. Chondropathy is obviously disease of the chondral surface of the hip, and as I said before, we see it strongly associated with labral pathology and also with FAI. We consider that it represents early hip osteoarthritis, so hip osteoarthritis in its early stages, perhaps even before we can see it on radiographs, and it's highly prevalent in people undergoing hip arthroscopy, and I'll talk about that in a few minutes. I think the important thing to realise is that this chondropathy that we're seeing is commonly observed in physically active people, not just elite sports people. So often we think of FAI as being a problem for elite sports people, but a lot of people presenting with hip pain and groin pain also have chondropathy, and these are often young people, so they're getting early signs of osteoarthritis but at a much, much earlier age than we normally associate with hip osteoarthritis. So in summary, we know that cam lesions appear likely to develop in adolescence and appear to be related to load, so particularly flexion and external rotation load. Cam lesions can increase the risk of hip osteoarthritis. We know that from two big cohort studies, but not all people with a cam lesion will go on to get hip osteoarthritis. So what we don't know is why some people with a cam lesion develop symptoms, but others do not. We know that cam lesions are related to both labral tears and chondropathy, and we need to identify the factors predicting the progression of cam lesions to osteoarthritis. So what is the evidence for surgical management, and in particular hip arthroscopy? And we know in Australia there's a lot of hip arthroscopy, and we know that the rates are increasing and they've doubled over the last few years. So the rationale for surgery is if there is a disease continuum between FAI, labral pathology, and then early arthritis and later arthritis, the theory then is if they cut out the FAI, cut out the labral pathology, perhaps they can slow down the progression of hip osteoarthritis. So what's the evidence that they can do this? Well, there's a large amount of anecdotal and opinion pieces supporting hip arthroscopy to say that it can improve symptoms and stop progression to hip OA in FAI. But we also know that there's a lot of studies looking at people who've had an arthroscopy for the knee, and we see that the evidence is not that clear. And Jo and I wrote an editorial last year saying that perhaps we need to take notice of these studies that have been done at the knee, and saying that that knee arthroscopy isn't necessarily more successful than conservative management to reduce pain, improve symptoms in the knee. And so perhaps we need to also look at similar studies to evaluate hip arthroscopy. Jo conducted a systematic review for people, a systematic review of outcomes following hip arthroscopy of people who are having an osteoplasty for FAI, and those who didn't, and to determine the outcome. What she found was there were large within-subject effect sizes for improved pain and function. So basically, if you look at the same people over time, pre and post-surgery, you get a large effect size or a large improvement in pain and function. And that can be up to 10 years for no osteoplasty and up to 3 years with an osteoplasty. And the main reasons for the differences in these pains is that there are fewer studies doing long-term follow-up because osteoplasty hasn't been done for as long as no osteoplasty. It does appear that the outcomes for hip OA are worse, but clearly we need more research in this area. There were few adverse events in the group, but the methodological quality was poor, and therefore we have limited confidence in the results from these studies. So at this stage, we have no evidence to say that hip arthroscopy can slow or reduce or prevent the development of osteoarthritis. And indeed, at this stage, there are no randomised control trials of hip arthroscopy, but there are a few being planned. Jo then looked at the prevalence of hip chondropathy at arthroscopy and looked at its relationship to patient-reported outcomes. And what she found in this graph, the prevalence of chondropathy is on the y-axis, and on the x-axis we have 3 different age groups, and then separating into men and women. So at first we have those who are 18 to 35, men followed by women. Then we have those 36 to 50, men followed by women, and then those 51 to 60. And no chondropathy, so no evidence of any chondral damage at all, is indicated by the brown. Mild chondropathy is in the blue and severe chondropathy is in the red. And you can see that as people age, they're much more likely to have chondropathy and much more likely to have severe chondropathy. And there's not a lot of difference between men and women. But interestingly, even those who are aged 18 to 35, very young people, more than 50% of those people already have signs of chondropathy, which obviously increases with age. And the overall prevalence of chondropathy is about 70%. So we're seeing in people who are presenting for hip arthroscopy, a lot of them already have early signs of hip osteoarthritis. How does this affect their patient-reported outcomes? These were Joe's data again. On the y-axis is their scores on the HOOS, which is the hip osteoarthritis outcome scale, where 100 is great and 0 is very poor. We then have 3 subscales: the pain, activities of daily living and quality of life. The black bars are the controls, and you can see they pretty much score 100 on each of the outcome measures. The blue is the patients at 18 months post-surgery, and then the white is 30 months post-surgery. And you can see for each of the outcome measures, the people who've had hip arthroscopy, even though they might be better than before they went in, still have significant impairments, particularly in quality of life, where their scores are about 50%. And you see there's no real improvement between 18 months post-surgery and 30 months post-surgery. So these people are still struggling with pain, activities of daily living and quality of life up to 18 months and 30 months post-surgery. Work done from Milana Ackman also shows that people aged 30 to 55 with hip OA, so young people, have significant reductions in quality of life compared to population norms. And these are some more data of Joe's where we particularly picked out some of the questions that we thought were really relevant regarding quality of life. So we asked, there were questions specifically about being concerned about their fitness, which is question 17. Question 18, which is pain after activity. Question 19 is pain will increase with sports participation. And question 20 being how much has your quality of life deteriorated? And now it's sort of reversed where the pain scores are on the x-axis and you can see the controls in the black have 100%. Now we have the severe and the mild chondropathies, and we can see for each of these questions they are significantly impaired compared to the control group, particularly in questions around fitness and activity and their quality of life. So we see that these young people with early evidence of hip osteoarthritis have significant impairments in their quality of life. So in summary, we know that FAI and associated pathology can cause hip pain. We know that CAM lesion is associated with an increased risk of hip osteoarthritis, but no evidence to date that this can be modified. We desperately need studies identifying risk factors for progression of osteoarthritis in those with CAM lesions. We know that hip arthroscopy is effective compared to pre to post, but patients remain impaired in their symptoms compared to controls. At this stage, we desperately need some RCTs looking at the efficacy of hip arthroscopy compared to a control group. And if we have greater knowledge of the hip impairments and clinical reasoning, if we have greater knowledge of hip impairments and combine this with clinical reasoning, we may be able to optimise our targeted rehab, which is what Joe's going to talk about next. So I just want to thank the people who've been involved in our current and previous studies, and in particular Joe, who's about to speak next, and our current PhD students, Josh, Matt and Peter, and thank you very much for your attention.
Hi everyone, and thanks Kay for that really interesting presentation. So following on from Kay's talk, what I'm going to talk about now is when we consider FAI, what is the current evidence that directs us to our best practice physiotherapy? And as Kay just talked about in detail, the typical hip pain patient with FAI is the patient who has that CAM lesion, which also coexists with labral pathology and often with chondral pathology. And we tend to see a continuum of the disease process where the young person with CAM FAI ultimately becomes the patient with labral pathology and chondropathy. So if we think about the factors that have the potential to impact on hip joint load, this gives us a really nice model to consider what are the things that we may target in our rehabilitation program. So what we see here is a model of factors that can affect stress within the hip joint. So in the middle of our picture here, we have hip joint stress. And this can be affected by extrinsic factors such as the type of activity that someone does, the amount of activity that someone does, or their body mass. And it can also be affected by intrinsic factors, so things such as the shape of the hip morphology, which we've just talked about in great detail, but it can also be affected by hip muscle strength and hip joint range of motion, and it can be affected by gait biomechanics. And these intrinsic factors can be affected by someone's age and their gender. And what we see in an optimal situation is that hip joint stress leads to reversible changes within the hip. But ultimately, when a threshold is crossed with the stress, we start to see irreversible joint damage, and this can lead to early hip osteoarthritis and ultimately advanced hip OA. So if we keep that model in the back of our mind, what evidence do we have for either non-surgical physiotherapy management or post-surgical physiotherapy management for people with FAI? So what is the evidence at the moment? Well, to date there is no RCT evidence supporting physiotherapy management for FAI or associated pathologies. The best evidence that we have to date are studies that describe impairments in people with FAI and also impairments in people after hip arthroscopy. So if we consider the evidence for non-surgical management, a systematic review was published 2 years ago now, where they looked at studies that examined non-operative treatment for FAI. And what they found was that the current themes that were presented in this systematic review were activity modification, physical therapy, a stage-based exercise approach, and retraining of core hip muscles, education and advice. But there are only 6 studies included in this systematic review, and those studies were generally of poor quality. So what about the evidence for impairments in FAI in people who don't undergo surgery? And this was a systematic review that was published last year in BJSM by the group at Melbourne University, where they looked at physical impairments and activity limitations in people with FAI. And in their systematic review, they included 16 studies, and these were generally cross-sectional and case series studies, so level 4 evidence. They found that people with FAI had reduced range of motion in all planes, particularly internal rotation and flexion, that they had reduced hip muscle strength in all planes, but in particular in hip adduction, abduction and extension. There was very little evidence for motor control in these patients, that functionally they had reduced squat depth, and for their gait they had reduced sagittal and frontal plane range of motion, and also reduced peak extension, flexion, adduction, external rotation and internal rotation. This was a study published last year in JOSPT, and this was an interesting study where they looked at 32 people with chronic hip joint pain, and what they found was that on the painful side, they had weakness in all of their hip muscles, but interestingly, they also had weakness on their unaffected or non-painful side in their hip abductors and external rotators. What about trunk impairment? And we know that the trunk is really important in people with hip pain. This was a study published earlier this year in AJSM where they looked at people with FAI and whether or not the amount of pelvic tilt changed the impingement in this patient group. And what they found was that those patients with increased anterior pelvic tilt also had increased acetabular retroversion, reduced hip internal rotation range at 90 degrees, and also reduced flexion, adduction and internal rotation range of motion. So it appears as though trunk control can alter impingement. We also looked at patients with chondrolabral pathology post-hip arthroscopy, and what we found was that they had reduced performance on the side bridge test compared to healthy controls on both the surgical and the non-surgical side. And we also found that better performance in the side bridge test predicted a higher International Hip Outcome Score, which is a measure of quality of life. So to summarise the trunk involvement, it appears that trunk control can alter impingement and that people with impingement pathology do have reduced trunk control bilaterally. So it seems as though trunk control might be an important target in our rehabilitation program. So what about the impairments that we see in people with impingement pathologies after hip arthroscopy? And we published this study last year where we looked at hip muscle strength and hip joint range of motion in people with hip chondrolabral pathology after hip arthroscopy compared to healthy controls. And what we found was that for range of motion, patients with hip chondropathy had reduced internal rotation compared to the controls, whereas the patients without chondropathy had the same range of motion as controls. For hip muscle strength, patients with chondropathy had reduced strength compared to the controls in most tests, whereas patients without chondropathy were only weaker in their hip adductors compared to the controls. We also found that women had reduced strength in their abduction, adduction and external rotation, and we found an interaction effect for chondropathy and gender for abduction strength. So women who had pathology were weaker in their hip abductors than men with pathology, and also women without pathology or control women. So the next question to ask is whether or not these physical impairments are associated with outcomes in people who have chondrolabal pathology. And this study was published earlier this year, where we looked at quality of life following hip arthroscopy in patients with chondrolabal pathology to see whether or not it was associated with the impairments that we saw in hip muscle strength and hip joint range of motion. And what we found was that in the people with chondrolabal pathology, having greater hip flexion range was associated with a better quality of life score. We also found that having greater hip adduction strength was associated with better quality of life outcomes. We were able to calculate the limit value for hip flexion range of motion, where flexion range of motion above 100 degrees was associated with a good quality of life outcome. And similarly for hip adduction strength greater than 0.86 Newton meters per kilogram was associated with a good quality of life outcome. So what about balance and other functional tasks? And this was a study where we looked at dynamic single leg balance in people with hip chondropathy. And what we found was that patients with chondropathy had a greater centre of pressure excursion in the mediolateral plane and also a greater standard deviation in the AP plane where they shook more than controls during a single leg task, a single leg squatting task. And what about particular angles during the single leg squat performance? And what we found here was that when we compared people who had had hip arthroscopy to healthy controls, we found that at the peak squat depth, so in the second picture in this figure, that patients with patients who had had hip arthroscopy had greater hip adduction angles and also greater knee valgus angles compared to healthy controls. We found that patients who had had hip arthroscopy on their operated side had a greater pelvic obliquity during the single leg stand compared to their non-operated side where their pelvis went into a greater tilt laterally. So to summarise, we found that 1 to 2 years after hip arthroscopy that there were deficits in the single leg squat performance, and we speculate that these deficits put the hip into a position of impingement that may increase hip joint impingement pathologies and help perpetuate the post-operative symptoms that Kay talked about in her presentation. So what is the overall evidence for non-surgical and post-surgical impairment? If we summarise this, we found that patients with FAI are impaired pre-operatively or non-operatively and remained impaired post-operatively when compared to healthy controls. That the impairments include reduced range of motion, particularly flexion and internal rotation, reduced hip muscle strength, and this appears to be sex-specific where women are more impacted than men, reduced functional task performance, increased impingement in a single leg squat, reduced trunk function, reduced dynamic balance, and also alterations in their gait. So now that we have an understanding of the impairments that patients have with FAI, what evidence do we have for physiotherapy treatment? So as you said, there is no RCT, large RCT evidence, but this was a study that we recently completed, which was a feasibility or a phase 2 trial for the efficacy of physiotherapy treatment for early onset hip osteoarthritis post-hip arthroscopy. Our primary outcome was a feasibility of a full-scale trial, and the secondary outcome was pain and function. So just to give you a brief overview of the study, our interventions, we had 2 groups. So our first group had a semi-standardised physiotherapy intervention, which we designed based on best practice physiotherapy with the best evidence that we have. So these patients had 8 treatments over 12 weeks. They had manual therapy that was targeted to increase their range of motion, hip muscle strengthening exercises, trunk strengthening exercises, functional and balance control exercises, and also education. And our second group was an education control group. who had treatment frequency the same as the physiotherapy group, so they had 8 treatments in 12 weeks. Within their education, they had advice for pain management, advice for general exercise, and advice regarding weight management. And just to summarise our results for our secondary outcome, which was looking at pain and function, we found that all patient-reported outcomes improved in the physio intervention group, and that the difference in the change score between the groups always favoured the physiotherapy over the control group. But none of these changes were statistically significant because we only had small numbers in this pilot study. So we have some preliminary evidence that a semi-standardised physiotherapy treatment regime probably improves pain and function post-hip arthroscopy, but we need to replicate these results in larger scale randomised controlled trials. So now to summarise, it's important to talk about, given what we now know about the evidence around physiotherapy impairments, what should a physiotherapy program for FAI include? So if we go back to that first slide where we looked at the hip joint load, if we think that our goal of treatment is to optimise hip joint load, we need to include these components. So we need to look at hip muscle strength, progressive loading that's sport specific, balance and functional retraining, trunk function, range of motion optimisation, and education. So what we know is if we think about hip muscle strength first of all, that all patients need strength in all of their hip muscles. So if we think about the different planes of motion within the hip, we know that for hip adduction, all patients need hip adduction strength, regardless of their gender or their pathology. Hip abduction strength does appear to be important for both sexes, but particularly for those patients with hip pathology. Hip flexion strength and hip extension and external rotation strength appears to be particularly important for women who have, and specifically those women who have pathology in their hips. So what about the functional, balance and sport specific and trunk function? Well, we know that they're all important to include, and what we need to consider is that we need to have both strength and endurance to reduce the joint load, that all of these activities need to be in a pain-free position. So they need to not take patients into their impingement painful position, and it needs to be a graduated loading program, and that their training needs to be specific to their sport. So if they need landing skills or cutting or kicking skills, that these need to be retrained in a safe and pain-free manner. So how do we optimise range of motion? We know that flexion range of motion appears to be particularly important, as it's a better flexion range is associated with better outcomes. So we can use things like soft tissue techniques, manual therapy techniques, muscle activation techniques, techniques that target the lumbar spine and pelvis. But I think the most important thing to remember here is that we need to take care when we're trying to optimise flexion range, as their flexion limitation may actually be protective and maybe keeping them out of that impingement pathology. So it's important not to try and push increased flexion range at all costs, regardless of symptoms. What about education? Well, this is really important that we include things like load management, the position of impingement, patient's pathology, and their prognosis and treatment options. So what do we mean when we consider load management? Well, I think it's really important that patients have realistic outcomes and appropriate education. We heard from Kay that while patients do improve after surgery, they're certainly not better when compared to a healthy control. And I think that if patients understand this when they go to surgery, they're more likely to be satisfied after surgery. It's important that patients with FAI have early hip OA. We heard from Kay that FAI is associated with a higher risk of hip OA, and that patients have pathology that's associated with early hip OA. So we need to treat them accordingly and include things like weight loss, general exercise and joint-specific exercise, and that this needs to be lifelong because their pathology is not going to go away. What about the position of impingement? And I think it's really important to understand that patients often go into their positions of impingement more commonly in their ADL than they do in their sporting activities. So if we can modify their activities and their positions during ADL, they may be able to, which takes up 90% of their time, they may be able to go into impingement positions in a pain-free way during that small amount of time that they spend playing sport. And what about their pathology and their prognosis? As we said, it's important to assume that FAI patients do have early hip OA and treat them accordingly. So they need to lose weight. For their general fitness, they need to find a sport that they love, but is also safe for them to do. I think it's important that patients understand they will have flare-up of symptoms from time to time and to not panic about that, but it's something that can be managed. They need to be prepared for an ongoing maintenance program that includes all of those things that we talked about, such as hip muscle strength, balance, and neuromotor control. And that patients understand that while they will improve, they won't ever be the same as a healthy age-matched control. When we think about our treatment options and our non-surgical treatments, I think it's very important that we remember that physio treatment does not have good efficacy. We don't have strong evidence at the moment. That in some patients, physiotherapy treatment may fail and require a surgical opinion. And as non-surgical treatment providers, we need to provide patients and surgeons with a high quality, efficacious treatment alternative to surgery, and we don't have this at the moment. So our take-home message for physiotherapy management of FAI is that our treatment goal is to optimise hip joint load using our best knowledge that we have to date of impairments. We need to remember that physical impairments exist non-operatively, pre-operatively, and remain there in people post-operatively for at least 12 months. Current rehab programs which are published at the moment tend to follow people for up to 4 months, and this is probably not long enough. Our studies have shown that patients have physical impairments for up to 2 years after surgery, and they need this ongoing long-term maintenance exercise. And that rehab programs, whether they're non-operative, pre-operative or post-operative, should include range of motion optimisation, strengthening, balance and functional training for at least 12 months. Their rehab program should be tailored to their sex and their pathology if we're going to optimise their outcomes. And that our level 1 evidence for physiotherapy management is also lacking. We really do need full-scale physiotherapy randomised control trials. Thank you for your time.
Great. Thanks very much, Jo, and also to Kay before you for 2 very comprehensive presentations that give a great sort of overview and about various aspects in relation to the development of FAI and also various treatment options and approaches. Now, we haven't got many questions coming through at the moment, but I urge everyone to ask any questions now before the webinar finishes. No question is too small, so please take this opportunity to ask your questions now. We do have one question that's come through that came during your presentation, Jo, and it was, what tests do you use to assess impingement pathology?
That's a really good question. I think it's really important to understand that what we would call our physiotherapy clinical tests don't stand up well on their own. So what I tend to do to assess impingement pathology is use a combination of patient-reported outcomes and symptoms, so the sorts of things that patients are describing. Look at their radiology. So Kay talked a lot more about their radiology, so using those sorts of assessment techniques. And then using our clinical tests that include tests such as the FADER test, so the flexion, adduction, internal rotation test, internal rotation measured at 90 degrees, and the Faber test. But I think what's also important to remember about those tests is that they're really good screening tools, which means that they have a high sensitivity. So that means that a negative test means that you can be fairly confident that the patient doesn't have impingement pathology. But if they don't have great specificity, so a positive test doesn't necessarily mean that the patient does have impingement pathology. So those special tests are good to rule patients out for having impingement pathology, but a positive test doesn't necessarily rule the patient in. So it's a combination of symptoms, radiology, and also clinical tests.
And Jo, another question, how do you strengthen adductors?
That's another really good question. I think it's important that the adductors are strengthened in a pain-free position. Often what you'll see clinically with these patients is that they will have weak adductors, but the longer prime moving adductors are also overactive. So you have to take care that when you're strengthening the adductors, you're not perpetuating that overactivity. But what I would generally do is start patients in a sideline position where the affected leg is on the bottom and the top leg is bent up out of the way with a pillow underneath the knee. And then just start by doing some isometric lifts, trying to almost lift their bottom leg up off the floor, so you're using the adductors. And then you can progress patients into a bridge position where they have a band around their knee and they're, again, using their adductors in an isometric fashion while they're bridging. And then you can progress into higher level activities like a side bridge type activity or a slider on one of those sliding board type activities as well.
Thanks, Joanne. Another one, what manual techniques do you use to increase flexion range of movement?
So one of the things, and again, this is just clinical experience, we don't have a lot of good research evidence for this, but what we often see in these patients is that they tend to have overactivity in a lot of their secondary stabilisers. So they tend to have overactivity in their psoas muscle, in their TFL muscle, often in the posterior portion of their glute med muscle as well. And that what we think happens is that this overactivity tends to create an impingement in the front of the hip. So I use a lot of soft tissue techniques, trigger point release and dry needling and those techniques in those muscle groups to improve their flexion range of motion. You can use manual traction techniques, but you need to take care with those because sometimes that manual traction may exacerbate pathology. So patients who have labral pathology or chondral pathology or ligamentum teres pathology, if you're pulling really hard in a traction position on their hip, you may exacerbate it. And I think it's really important to consider the pelvis as well and the lumbar spine. So often pelvic and lumbar position will create an increased impingement. So treating those things can also improve their flexion range of motion.
Jo, when you spoke before about the research looking at the education and the physiotherapy, what form did the education take? Was it just in discussion with the patient or was it information leaflets? Did you find a particular method work better than other ways?
So what we did in the pilot study that we talked about is the patients came in and had a 30-minute session face-to-face with the physio 8 times over the 12 weeks. So in that session, they spent that 30 minutes having a detailed discussion with the physio, but they were also given a comprehensive handbook which had a lot of other detailed information in it. And then, if required, they were given information regarding things such as weight loss and more specific things that as physios we couldn't address, but they were pointed in the right direction for those things as well.
And a good question, are there any current FAI guidelines?
That's a really good question as well. So we have some really good guidelines for physio management for more advanced hip OA. There are a number of papers out there where people have published their own individual protocols for rehab for FAI, but there are no, I guess, consensus guidelines at the moment in terms of the management of FAI, unfortunately.
And I can't let Kay get away without having a question put to her. So, Kay, you mentioned earlier about the cam-deformity development, particularly in that group of young boys engaged in physical activity and so on, and you did say that more research is required. But what might be some of the potential sort of issues that are looked at there, and what might be some of the implications for the management of adolescents and their sort of physical activity and exercise?
Yeah, that's a really good point because clearly we want people to be physically active and we want adolescents to be physically active and to stay that way. So I suppose that one of the big unknowns is when they get the cam lesion, so that it develops during adolescence, we don't know exactly who's going to develop that and who isn't. And there is a genetic component to that as well. But in those who develop a cam lesion, not all of them are going to go on and get even hip pain, let alone osteoarthritis. So it's that missing link really. The problem with those sorts of studies is clearly you've got to follow people for a long period of time. Obviously they go through, the studies that have been done are 12 and 13-year-old boys. If we wanted to look at girls, for example, we'd need to start even earlier because they have to go through adolescence earlier. So there are a lot of barriers to doing that sort of research. One of my other PhD students, Andrea Moser, she's doing a longitudinal cohort study now looking at risk factors for developing hip pain, and a cam lesion is part of those measures, but also some of the clinical measures we spoke about as well. So there is a lot more that we need to do. We need to know more about what happens to girls as well, but we need to know, how much load. I mean, the one study that looked at load was in a retrospective study of one football team. So how much load is required, what types of loads, and over what sort of period of time. So But unfortunately, those studies are particularly difficult to do because you need a fairly long period of time to do them.
So a question has come through saying, would you encourage a variety of exercise for 12 to 13-year-olds rather than a, engagement in a single sport?
And it's a huge problem within the sport because obviously there's a desire, if you like, to get a certain number of hours in of training, particularly kicking in soccer, for example, in young boys, in order to get you to the skill level that they think you need to play at a high level. Certainly a variety of exercise is going to load the bone and the hypotheses in different directions, which is going to be good for the joint. Whether it then stops them developing a cam lesion, we don't know. But ideally, I think for all adolescents, you look for a variety of loads in a variety of different directions, for sure.
Well, given that we're pretty much just on 5 to 8, and I don't think there's any last questions coming through. So, look, on that note, I would just like to thank you sincerely, Kay and Jo, for both your presentations. I mean, you've obviously identified that a lot more research is required in different elements to do with sort of FAI and associated conditions and so on. So, look, thanks so much for your very informative presentations tonight. I'd encourage and ask all participants to complete the exit survey, which will come up on your screens just a few seconds after we finish up. So, oh, sorry, we've got one last question. I think we'll address it to you, Kay. It's like an auction just before we finish up.
Yeah.
Can we help or participate in further research? There's an offer for you.
Yes, thank you. Clearly we need a lot more research, and as Jo mentioned, there are a number of studies going on in Australia and around the world, but there's always room for people to help with research. We're recruiting into a couple of different studies at the moment. Jo's currently doing an FAI clinical trial in Ballarat, so if you have any patients that you want to get off that you want to refer into the study, feel free. We do have students that are involved in research, but there's always room for more people to be involved in research. So I can be contacted easily at Trobe. I'm fairly easy to find, but I'm sure you can get my email address from Arthritis Victoria if need be. And we're always looking for either participants to come into studies or for people to help out. It's a lot of work to be done, so there's a lot of opportunities.
Great. Well, that's nice if you two can gain something from tonight's webinar apart from the audience and the benefits they've gained. So, look, thanks very much, Kay and Jo. And on that night, I'll say good night all. Thanks very much for joining us this evening. Good night.
Thank you. Thanks.